Okay, and you will all see a message that the meeting is being recorded. And those on Teams via the computer should see the message at the top of their screen. But those of you who are calling in, I just want to remind you all that we are recording this meeting. You may want to announce yourself as we go through the attendance. Melissa is going to take the attendance for us. And per Governor Lamont's executive order, all public meetings must be recorded or transcribed and made available to the public. Additionally, today's meeting is being covered by CTN. Therefore, in order to ensure a quality recording, I ask that everyone please mute their phones at this time and remain muted unless wishing to speak. Also, to assist in making the recording clear, please announce your name each time you begin to speak. Melissa is going to take roll call. And Melissa, I will punt over to you, please.
Okay, great. Thank you. Good morning, everybody. Thank you for joining us. I'm just going to call your name, and if you could just verbally announce your presence, that would be great. I know we have Barbara Cass and Nicole Godburn. Do we have Matthew Barrett?
I am present. Good morning.
Judy Dowd? Mag Morelli?
Here, thank you.
Dan Lerner for Mairead Painter?
Here.
Michael Morris?
Present. Good morning.
Claudio Gualtieri? Senator Moore?
Here.
Representative Abercrombie?
Here.
Senator Berthel? Representative Case? Senator Daugherty Abrams? Representative Steinberg?
Here.
Senator Summers? Senator Huang? Representative Pettit?
Present.
Senator Austin?
I'm here.
Representative Walker?
Present.
Senator Minor? Representative France? Moving on to our distinguished guests, is Commissioner Gifford with us today? Commissioner Giuthani?
Present.
Lita Orfici? And is there anybody else who I have missed who would like to announce themselves?
Lawrence
Nick
Santilli, Athena Healthcare. And
I'm
CEO
sorry,
of
who's
the,
that from Athena Healthcare? I couldn't catch that.
Lawrence Santilli.
Oh, hi, Larry. Thank
How
you.
you doing?
Hi, Melissa. This is Owen Rude from OPM.
Oh, good morning, Owen.
Hi, it's. Go ahead. Emily Shepard from OSA.
Hi, Emily. You know what might be easiest for guests is if you just put your name in the chat, and then we can get right into the meeting. That way people aren't trying to talk over each other. And I'm sorry, Bill, I forgot to add you to our list. So I do just want to officially call on Bill Halsey, who is joining us in place of Kate McAvoy, who left for another position. Good morning, Bill.
Good morning, Melissa. Thank you.
Okay, Barbara, I think we're all set.
Thank you, Melissa. And again, I want to welcome everyone to our first quarter meeting of 2022. And thank you for all of the important work that we do as a result of this meeting. First thing on our agenda is a COVID-19 response update. And I'll start off and then I'll be augmented by Nicole Godburn and Dan from the Long-Term Care Ombudsman Program. So sadly, we are going into our third year working and fighting COVID-19. We have seen many different variants that at DPH continues to keep us heavily immersed in the work. And thank you, Commissioner Jitani, for attending our meeting 2022. I do want to welcome Commissioner Jitani not only to our advisory committee, but to the Department of Public Health. She has just been tirelessly working, and I don't need to sing your praises, but I am one of your best cheerleaders out there. We are so glad to have you. And the work has not been easy. Oh, thank you, Commissioner.
Thank you.
Again, we are in our third year. And while we hoped that this had been in our rearview mirror, it is still first and foremost on our radar screen. Since Commissioner Jitani's arrival, she has had to do several commissioner orders. We know that nursing homes are experiencing, in many cases, significant issues with staffing. And to address that, Commissioner Jitani did sign and execute a commissioner's order that temporarily suspended out-of-state practitioners, and that was recently their licenses. They can practice in Connecticut and not have to apply for a license. That was a carryover commissioner's order from early on in the pandemic, and it was very helpful and very supportive in the healthcare workforce issues that the sector was experiencing. That was recently modified to include respiratory therapists. Also, since we last spoke, we have had that are relevant and pertinent to DPH, a few new executive orders that speak to vaccination, which is Executive Order 13F, and requires reporting and vaccination status for all covered long-term care workers in the long-term care sector, which included nursing homes, ICF IIDs, chronic disease hospitals, residential care homes, managed residential communities, and assisted living services agencies. And that was recently revised on January 6th, 2022, with Executive Order 14B to include boosters. So we are in the midst of preparing our guidance document for Executive Order 14B, but this is a way for the department to get assurances. We know vaccination is critically important to transmission. In terms of transmission in our nursing home sector, we are seeing many nursing homes, upwards of 200 nursing homes of our 205 that have had some level of incidence in the nursing homes. But we are not seeing the significant impact to residents as we did early on in the pandemic because we have vaccination and we have testing. We continue to work with our nursing homes. We were doing a industry call every other week, and for the month of January, we are going to be moving that up to a weekly call. Lots of movement, lots of activities in nursing homes. And again, I started off my update regarding staffing, and we know that that continues to be impactful to the operations in nursing homes. And there are a variety of, issues that collide with that. Access to the workforce, staffing agencies, So we will continue to work with the industry on that. I will stop there and pass over to Nicole.
Thank you, Barbara. For those who don't know me, I'm Nicole Godburn. I'm the Fiscal Manager of Rate Setting and Reimbursement with the Department of Social Services and the Medicaid Program Division of Health Services. So I would like to recap the financial supports that have been given to nursing homes since the start of the public health emergency. So this will give everybody kind of a history of where we started back in 2020 and where we are at today. So initially in March and April of 2020, the department issued 10% Medicaid rate increases to nursing homes. The approximate value of this was $28 million. And then these states received federal coronavirus relief funds, and with those CRF dollars, we issued grant payments to nursing homes in April of 2020, which approximated about 10% rate increases. Then we issued in May and June of 2020 CRF grants that approximated about 20% of rate increases. So the total value for this period was about $48 million that was issued in CRF grants to nursing facilities. We also issued additional CRF hardship payments in the amount of approximately $500,000 to homes that came forward and said that they had additional costs and were able to justify those costs. And then we issued them additional supports. So that was about $500,000 that were issued. We also leveraged CRF federal dollars to support the opening of COVID recovery facilities. This was done in conjunction with the Department of Public Health. This was in 2020, where we had buildings, and I'd like to acknowledge Larry Santilli from Athena. He absolutely stepped up, and his buildings were a big participation in this program, where we had the COVID recovery facilities that helped to handle the overflow from hospitals and from other nursing homes. Homes were given about a per diem of $600 per day to care for those residents, and the total approximate value was about $12 million that was issued through this program. Then in January and February of 2021, we issued 5% rate increases for nursing homes. We also did 10% Medicaid rate increases in March of 2021, and the total approximate value of this was $18.8 million. We also issued a temporary 10% Medicaid rate increase for the months of July 2021 to March of this year. That 10% Medicaid rate increase is in play right now. Nursing homes are receiving that. That approximates to about $85.8 million. We also have currently in play 4.5% increases to nursing homes. This money is specifically to be used to support staff wage increases. So that money was issued to the facilities in July of this year. The facilities are currently receiving that, and that money will also be issued again in the next fiscal year. So that 4.5% will carry forward. We also issued approximately $30.8 million in state fiscal, we'll be issuing approximately $30.8 million in state fiscal year 2023 for rate increases for nursing homes that are able to provide enhanced employee healthcare and pension benefits. So for folks who are familiar with our prior health and pension benefit programs, this program will mimic those programs. We will be this month posting applications to the DSS website for homes that wish to participate. They can come in and apply to this funding pool to be able to receive those additional dollars. So I encourage folks to keep an eye on the DSS webpage. That information will be posted shortly so homes can come in and apply to this fund. There's also currently a total pool of approximately $5 million, $2.5 million in state share for each fiscal years 22 and 23. This money is specifically targeted to help nursing homes meet the new DPH requirement of 1 full-time social worker per 60 nursing home residents. So we know that homes may need additional financial supports to meet this requirement. So homes can go to the DSS nursing home webpage. There is an application process where they can send in their request to us, and then we can go ahead and issue that money to them. There is also another pool of approximately $1 million in each fiscal years 22 and 23 for targeted rate increases to support nursing homes to meet the minimum staffing level requirement of 3 hours of direct care per resident per day. We suspect that many homes are currently meeting that, but if any home is not meeting that particular requirement and they need those additional financial supports, They, again, can go to the DSS webpage. We have that application available to them, so please submit those documents to us, and we will review and issue that money to you. And with that, that gives a very brief overview of where we are currently at today, and I will turn over to Dan.
Thank you, Nicole. Thank you, Barbara. I'm Dan Lerman, Regional Ombudsman in the New Haven area, sitting in for the State Ombudsman Maraith Painter this morning. I'd like to raise just a couple issues, piggybacking on the issues that Barbara and Nicole have presented regarding staffing. We're hearing many concerns about unmet needs at many nursing homes across the state due to staffing concerns. Also, with the spike in COVID cases, there's resident concern that some staff resources will have to be allocated to dedicated COVID units versus non-COVID units, further accentuating some of the staffing challenges. Those are the general issues that I wanted to present today, again, highlighting the staffing concerns that we're hearing.
Thank you, Dan. Thank you. Shall I move on to the next agenda item, which is the COVID Recovery Facility funding update? And while primarily this is a DSS initiative, I am always happy to report that we at DPH and DSS celebrate really have a partnership. And while the funding was issued from DSS, we have worked in collaboration with Nicole and her team and Bill, of course, to ensure that the money that was sent to nursing homes is being utilized in the fashion that it was intended to be. So we do have an awareness at DPH of the dollars and the nursing homes that did receive the funding. We monitor that through our survey activities, particularly the Infection Preventionist Initiative, the infection control coaches, staffing, and then we work with DSS on next steps. So I will stop there, Nicole, and pass over to you for the real update.
Thank you, Barbara. I'd like to just point everybody to our DSS nursing facility webpage. If anybody would like the history of the CRF funding supports, Barbara mentioned, for example, that the money was issued to homes for specific uses like infection control prevention. The money was also in support of helping homes to address if there were 3 and 4 bed occupancy configurations in buildings. Money was also used to help support and enhance employee staffing. So the CRF dollars in particular were given for a variety of different uses, and we have that history on the DSS webpage. So if you go to the nursing home webpage, we created a separate section called Public Health Emergency. And if you click on that, you'll see the entire history of those dollars and the times in what it was issued for and the periods that it was issued. We do, as Barbara mentioned, work very closely with DPH, and if there's questions from the facilities, we work collectively to be able to address those questions. If there's concerns that are identified, we work collectively to be able to address those. So we do work in collaboration to ensure that the funding is used for what it was intended for and to support the homes in understanding how to execute and use that money. So with that, Barbara, I will toss that back to you if there's no questions.
Okay. Next on our agenda is survey activities and quality issues. And on the last few meetings, I have reported off that our survey activities have been not as robust as our historical activity has been. In March of 2020, CMS did suspend survey activities across the healthcare continuum for all certified activities, with the exception of complaints that rose to the level of immediate jeopardy or a significant threat to life and safety. CMS has resumed survey activities. We have resumed our nursing home certification schedule. And again, we are in have a backlog plan that has been vetted and approved by CMS to catch up. So we are calling it a DPHR catch-up plan. We are out there every week with teams. I will let this group know that just as with the healthcare sector, our activities are also being impacted by absenteeism as well related to COVID positivity. But we continue to conduct our activities. We are out there doing complaints. We continue to talk with family members every day. And for the last quarter, we did have an immediate jeopardy situation at one nursing home related to pressure ulcers. That facility, we worked with them to get an action plan, and they are back in compliance. I will stop there unless there are any questions and move on to the next agenda item.
Thank you, Barbara. So a quick overview of receiverships, closures, and bankruptcies. So we currently have one home in receivership. We have had 0 bankruptcies. We have had 3 closures since February of 2020. We would like to note and point folks again to the DSS webpage where we post the monthly census data for the nursing homes. And we have begun on the monthly census reports to track the number of closures and to track the number of bed delicensures that come in and are approved by DPH. We often get questions on how the industry is doing, where beds are located, are homes delicensing beds. So we've begun to track that information on the monthly report. So you can see that the most recent information that's posted is for December. We should have January's numbers by I would say by mid-February. So usually about the middle of the month is when we get the prior month's information. So we post that as quickly as we get it. So you can track that information through the monthly census reports. And with that, if there are no questions, then Barbara, I will move straight then into an update on the transition to the acuity reimbursement or the case mix system, as many folks have. Matt, I'm sorry.
Yeah, I'm sorry, Nicole. Yes, I'm sorry. I have a question. Okay. Very quickly. Can I ask who is in receivership?
Yes, we have one building that's been in receivership since the end of 2019, and that is Waterbury Gardens.
Waterbury Gardens, okay. And I didn't have a chance to jump in and ask one other question. When you said that we did the executive order about licensing so that we could get more people into the state to fill those gaps, do we still do the background checks on the people that we are doing them with?
Yes, Representative Walker, that is done at the local level. So the employee does have to go through the ABCMS, as we call it, a DPH criminal background check program. We resumed those activities last summer.
Okay, I just when I heard that, I didn't hear background checks and I just got a little concerned. And one other one, the 4.5% increase on staff wages in July, I didn't get, how much was that amount, that dollar amount, Nicole?
We can get that for you, Representative Walker. Because it's based off of the rate, we'll need to do a little bit of a calculation because it's based off the rate in the billing that comes through. Okay. So we can get that information to you.
Awesome. Okay, thank you. Thank you very much. Thank you, guys. Go right ahead. Okay.
I do see an additional question, if I'm not mistaken. I see a hand raised, and I'm sorry, I can't see everyone, so I'm not sure who that's from.
It's me, Meg. And if I can try, I'll try to get the hand down when I'm done. It took me a while to figure out how to raise it. I I just wanted to make a comment when we talk about delicensure of beds and closures, that any significant delicensing of beds needs to go through a nursing home CON process. So it's not a hasty or rapid process for any nursing home. So I just wanted to clarify that as we could, because we'll probably be talking more and more about delicensure and right sizing of the sector, and it does require a CON process that goes through DSS, unlike the hospital CON process. So I just wanted to raise that.
Yeah, thank you, Mag. And I'll piggyback off of that. So Mag is 100% correct. I mean, delicensure, it's not a quick process. It's not a process that we take lightly. We take it very seriously. So if a facility is looking to do that, they, yes, do have to come in for a certificate of need. That does go through our unit. And the review, we work with the nursing facility to understand what they're looking at to do with the delicensure. We look at the geographic area. Usually we look at a 15-mile radius to ensure that if that delicensure was to go through, that we are not going to adversely impact that area. We do not want to leave a region short of nursing facility beds. So we make sure that that delicensure would not adversely hurt the area need. So we go through that process. We do a deep dive, do a very deep look. If we then approve it, we then work in conjunction with the Department of Public Health, because the Department of Public Health is actually the agency that licenses the beds. So then they have a process that they then need to go through with DPH to actually then take those beds offline. So it is, Mag is correct, it is a process that we do look into and work closely with the nursing homes and our sister agency before we actually approve that delicensure.
Nicole, if it's appropriate, I'd like to make just several observations and then offer our longstanding chairman of our board of directors, Larry Santilli, if he wants to add anything to it. Or would you like me to hold my observations until you continue with the reports?
It's up to you, Matt. I mean, if you'd like to wait, I was going to just do kind of a quick overview of case mix, and then we can open it up if you'd prefer.
That's fine. Yeah, go. Please proceed, and then I'll comment after. Thanks.
Sure. Thank you, Matt. So to give an update on case mix or a transition to acuity reimbursement, to recap for folks, this has been a process that we've been working on with the associations and the industry for several years now. The transition to an acuity reimbursement method, to recap for folks who maybe are not necessarily familiar with acuity, essentially what it does is it looks at your case mix of your building, or what the need level of your residence is, and will reimburse you based off of that need. So theoretically, the higher the need of your residents, the more money you will receive. The less the need, the less resources you are utilizing, and then the lower the reimbursement would be. So that's the theory behind acuity and case mix. So we met with the industry and the association last quarter. We held a stakeholder meeting, and we were able to issue and work through getting shadow rates to each of the buildings quarterly. We understand the transition to acuity and case mix is one that is kind of new. It's a newer concept. So we want to be able to, ahead of the actual transition, which is set to take place in July 1 of this year, we want to get shadow rates to those buildings, to the nursing facilities, so they can see what their rates may potentially look like under an acuity system. This will give them some predictability, an opportunity to plan as we approach the July 1 date. So each nursing home is now receiving quarterly reports showing their shadow rates through a secure portal. Each nursing facility has a secure portal with DSS. Those secure accounts are a way for us to be able to transmit secure information to the homes, and for the homes to send secure information back to the department. And through those portal accounts, we are transmitting shadow rates to each nursing home. The department issued Q3 2021 shadow rates to the homes in October of last year. The Q4 shadow rates will be issued to nursing facilities this month. So we expect those shadow rates to go out at the end of January. The shadow rates, the acuity reimbursement is based off the MDS, or the minimum data set that is information that the nursing facilities submit based off their resident acuity need, and we leverage that information, which is information that they're required to submit through CMS for Medicare reimbursement, and we just leverage that system to be able to calculate the acuity. The department has worked very closely with the industry and the associations to develop a phase-in plan for acuity. I mentioned that the go live date for acuity is July 1 of this year, but what we're going to do is phase it in over a period of 3 years. That phase-in will allow the nursing homes some predictability. It will allow them time to adapt and to adjust. So we have developed this 3-year phase-in plan in conjunction with understanding and receiving lots of feedback from the homes and from the associations. And based off that feedback, we've developed this 3-year phase-in plan. So a reminder on the methodology is that the acuity component, the case mix component, will only touch the direct care component of the nursing home rate. Nursing home rates are set on 5 individual components, but acuity only touches the direct care component. The base year for acuity will be the 2019 cost reports. Initially, the department was looking to use the 2018 cost reporting year, but we understand the concerns of the industry and we updated that to use the 2019 cost reporting year. There will still remain 2 peer groupings when we calculate the rates, so there will still be a Fairfield County peer grouping and a non-Fairfield County peer grouping. And the acuity will be phased in over the next 3 years. And this will allow providers time to understand the impact, the operation of their system, be able to make internal adjustments to adapt. And the way that we're going to phase this in is we're going to use stop gains and stop losses to really control and throttle the rate over those 3 years. So in year 1, the parameter that we'll put in place is that no home will lose money. So there'll be a stop loss of 0, but there'll be a stop gain of $6.50. So no home, if under an acuity system, you see your rate increase, it will not increase more than $6.50, but no home will lose. In year 2, those guardrails will open up a little bit. So the stop loss will be $5 and the stop gain will be $20. And then in year 3, the guardrails will be removed and the system will run openly. And during this time, we will absolutely be stakeholdering with the industry. We want to hear feedback. We want to hear how things are going. We are very much open and wanting to work and understanding how the system is working for folks. We have shared the model with the associations and we'll be holding stakeholder meetings with the industry coming up to do a deeper dive into the model and to get their feedback as we approach the July 1st date. So we have a plan. We are approaching it. We are wanting that feedback and to hear how things are going as we get closer to that July 1 date. So with that, if there's any questions, it can get very technical. So I know it can get a little confusing. So if anybody has any questions, I'm happy to answer.
Matt, your hand is up. Is that a legacy hand or?
No, it's not directly related to acuity. It's just for the opportunity to comment and provide some industry observations on the on all of the reports.
So Barbara, if there's no other questions on this, if we wanted to go to other business where I think we could probably generally open up if.
Perfect.
Okay.
Thank you. Are there any questions, comments, concerns that the group would like to bring up? So Matt, please go ahead.
Thank you so much, Barbara and Nicole. And I want to begin by especially acknowledging Commissioner Giuttani and her team at the Department of Public Health, and for the whole team led by Nicole at DSS. I think the hallmark of Connecticut's response to the COVID-19 pandemic public health emergency right from the beginning a hallmark feature has been the collaboration and partnership that formed between the industry and the executive branch, and it continues, and I would characterize it as a very strong partnership and helps to explain our successes during the public health emergency. I want to begin by saying, yes, nursing homes are experiencing the trauma of the Omicron surge in Connecticut, in our state. And the statistics that Barbara Cass so ably went through really kind of speak for themselves. And this is happening and helping to fuel the most significant staffing shortages, and Larry will comment on this in a moment, that we believe have ever been experienced in the sector. The demand for labor and the associated cost increases with staffing our buildings is also the most significant that's ever been experienced in the sector. And this is on top of what the Consumer Price Index is reporting as a 7% inflationary increase in December that we don't expect to be abating anytime soon. These significant staffing shortages are so severe that nursing homes have been reporting all across the state for many weeks now an inability to meet their fundamental requirements to staff sufficiently to address the care needs of their residents. And many nursing homes report an inability to take admissions across the state. We hear that more and more on a daily basis. But I do want to also say that we are concerned that some of the labor cost increases we find untoward, so much so that we, both Leading Age Connecticut MAG and the Connecticut Association of Healthcare Services, me on their behalf, have written to Attorney General William Tong to ask him to review what we allege to be unscrupulous pricing practices of these nurse staff agencies that have become a prominent part of their response, the necessary response in many respects that is caused by these staffing shortages. All of this adds up to the staffing shortages are hindering the occupancy recovery and the financial recovery of the sector that we were estimating, apologize for that interruption, that we were estimating, would be the case earlier in 2022, but now we believe that our occupancy recovery, because of not just Omicron, when we were talking estimating our recovery periods, we hadn't even experienced the Delta surge, let alone Omicron, let alone the severe impact on staffing that we're experiencing. So the occupancy recovery, although we're at 70%, 78%, as Nicole reported, I do want to say that we are almost 6 points higher than the national occupancy average, and we are moving steadily forward. But nevertheless, the occupancy recovery that we have discussed on these Nursing Home Finance Advisory Committee calls is significantly hindered by all these dynamics. And with that, with your permission, I'm happy to acknowledge our longstanding chair, Larry Santilli.
Oh, thanks, Matt, and thanks, everybody. And it's been quite the partnership with DPH, DSS, Barbara, Nicole. You guys have been amazing, through this 2-year process. And we're only here because of all of you. If we didn't get the funds from DSS, HSS, people, PPP loan, we wouldn't be here. But now we're going into another phase, and I did have discussions with the governor on this. I did on Lieutenant Governor, and I also did on the commissioner. The crisis we're having right now, it has never been like this. And the reason that it's so bad is that we need the pools, so they are then allowed to charge whatever they want. I had one pool charge me $84 an hour for a nurse's aide. I had another pool come in and post their rates so they can steal my employees. So this is a war. And unfortunately, we don't have caps on the pool. I had mentioned that to the governor. And if we don't do something about this, it's impossible for us to get the staff back from the pool. So that's our first problem. Our second one is the hospitals are in the same boat we are, and they've got almost 2,000 cases right now in the hospital, 1,980, I think. So we've been working with them, but there's only so much we can do when we're short-staffed. And I know how horrifying it is for those workers that they've got people in emergency rooms. They have nowhere to put them. And we're the ones that are supposed to step to the plate. But how do we do that when we can't get the staff? The other problem is in the past, when the pools would charge these exorbitant rates, they could never guarantee 8 hours, 40 hours a week of staffing. Now they can guarantee that and then some. So that's the added advantage that they have. So Massachusetts, by the way, does have caps on pools. Other states do. So that's one area. The second one is the nurses' aides. When you look at their average hourly rates and what they've gone through in 2 years, do you really think we're going to be able to expand that population when you have other areas like Home Depot, simpler jobs, easier, less stressful, that pay more? So, I mean, I did a study for Massachusetts, and we were at 48% higher cost than we were in 2019. The average hourly rate that I'm paying is $67 an hour for an RN, with all the bonuses, $300 shift bonuses, comes out to $32. And with all that, we still can't get the staff. So, unfortunately, Nicole, we're going to be sending you a report showing what we're doing as an industry and what we're spending. And we're so thankful for the 4.5%, 5%, the 10% for the revenue loss. But we're going to commit probably around 30, 40% higher wage cost. And we need relief now. I mean, I just don't know. And that's the whole reason behind the 7-8% not going up, Matt, is because people are saying no to admissions. You could check with the hospitals, and obviously would tell you that, because we don't have the adequate staff. The pool staff also that we're paying a fortune for, they're not part of our team. They don't give the same care, quite frankly, as our team does. But we don't have a choice but to use them. So what we were trying to do as an industry was give out all these bonuses, not getting paid for it. We're not getting reimbursed for it. And it's nobody's fault. It's not Nicole's fault. It's not DPH, because they didn't know it would be like this. It is like this now. So we've got to find a solution so we can help the hospitals too. I've done my best. I've taken probably 300 or 400 cases from them that have been, COVID. But I wish I could do more. I wish I could open up the COVID, all COVID facilities, but where's the staff going to come from? So we have a crisis here, and it's got to get rectified soon. And it's not going to go away a month from now when this virus goes down. We all know we're at the tip right now. 3 or 4 weeks from now, we'll probably be at 10% of where we are right now, but our staffing will not go away. That problem is not going to go away. We have to find a way to cap the pools. We have to find a way to give an average hourly rate for nurses' aides that brings them back into the industry. That's all I have. Sorry for the bad news, but that's reality.
No,
Thank you, Matt. Thank you, Larry.
Yeah, thank you, Larry, for that. And Larry, yes, I do look forward to your reports. Just for everyone's benefit, we work very, very closely with Larry and other operators and owners of buildings. And we want to hear from them of what their financial issues are. That only helps us to understand what they're currently going through, so we can kind of craft ideas and ways that we can support. So Larry, thank you. So we look forward to that, Larry. So I very much appreciate the heads up that you'll be sending something.
Well, thank you, Nicole. You have been amazing, and so has Barbara. That's all I want to say again. It's just, what a team. That's all. Thanks.
Thank you both very, very much. Good morning, Representative Abercrombie. Your hand is up. Do you have a question, a comment?
Or
Thank
a
you.
couple of them. Yes, thank you very much, and Happy New Year to everybody that I haven't seen before this call. Just a couple of follow-up questions on the whole presentation. Number one, in 2020, when we started giving the nursing homes some added financial relief, we also talked about an audit to make sure how those dollars were being spent. Was that done?
Yes, Representative, yes, the audit was done. There were, and what I can do is I can pull all the information together for you and craft a report for you to send to the group. There was an audit done. There were some recoupments that took place. We worked closely with each of the buildings to understand how they spent the money. if a building was not able to substantiate how that money was spent, it was recouped. So I can craft that for you and get that information to you.
That'd be great. Thank you very much. I think my colleagues would be interested in that also. Second question, in the budget that was passed and signed by the governor in June of 2021, we put $10 million in ARPA dollars to kind of help the lower calculated rate nursing homes to bring them up. What's going on with that $10 million? I know we're moving to an acuity type system, which I think everyone is in favor of. I've talked to Meg and Matt about that through this whole process. I know this has been something in the works for at least 3-4 years now, but what about that $10 million? Where are we with that?
Representative, I would invite colleagues from OPM to comment on that. But my understanding of, because I believe you're talking about the 10 million pool that was to help bring down the gap between the issued and the calculated rates for nursing facilities. Yeah, that 10 million, I believe, was leveraged towards to help the phase-in plan of the acuity system, because that money could be injected into the system to help decrease that particular rate and to help support the acuity. But I invite my colleagues from OPM to weigh in since the pool sat with them. So Owen or Sue, I'm not sure who's on the line if you want to comment on that.
Hi, Nicole. Thank you. Sue Mosman from OPM. So those dollars were on hold because we had decided that a more sustainable method was to infuse the general fund dollars to get us to more of the rebasing and address that more holistically. And that's what we would be phasing in beginning in fiscal year 23. So at this point, I don't, as I said, I think those dollars are on hold.
Okay, so this might have to be an offline conversation with OPM about this, because legislatively that wasn't our intent. And because the acuity-based system is not till 2023, I still believe that those nursing homes that are in that financial distress could use those dollars now. So we'll continue that conversation at a later time. But thank you for that update. My other question is, and I'm not so sure this is a DPH question or the nursing homes that are on here question. My understanding is that we have, we're having a difficult time due to staff to bring individuals that should be out of the hospital to nursing homes, especially if they have COVID. So what's the long-term thoughts on being able to, I know one is a staffing issue. I think the second piece is, and it goes to what Barbara was talking about, perhaps COVID units. Are any of the nursing homes thinking about being able to craft these COVID units at a few of their facilities so that we at least have a place to move individuals? I think that it's a little short-sighted of us as a state to think that just because Omicron is hopefully going away, we all know there's going to be more variants. We all know we're going to be in this pandemic for a while. And so we need to start thinking about what's that going to look like. And we know it's more expensive to keep individuals in hospitals than it is to move them to nursing homes. So is there a plan as to how are we going to do that? And then the second piece of that is, my understanding is, and Barbara, correct me if I'm wrong, when we did the COVID units, we were able to get some Medicare dollars because of the way and Kate is more, and I know she's not on here, but she was more of an expert on this, but under Medicare, if somebody spends so much time in a hospital and then is moved to a nursing home, there's Medicare dollars that follow. So is that still the case? And is there an opportunity for some of these nursing homes to have the ability to open COVID units as we go forward?
So Representative Abercrombie, thank you for that question. And I want to assure you and everyone on the group that not a day goes by at DPH that we don't talk about the staffing crisis that we are all currently experiencing. Excuse me, this is impacting each and every one of us across the sector as well. And the decision to move forward with a COVID recovery facility, an independent one versus a dedicated unit, is also in those daily discussions. I, at the end of my comments, would welcome comments from Matt, Larry, and Mag on that as well. But we have been working with providers, providing technical assistance in helping them establish dedicated units within their facility if the numbers of positivity or incidents should rise. So that's currently happening right now, Representative Abercrombie, not with meteorific trajectory, but it is currently happening. I know, Larry, you've established a unit in one of your buildings. We talked about it over the weekend. And then my second comment would be related to the Medicare rate and the Medicare dollars. Early in the pandemic, Medicare did, the Centers for Medicare and Medicaid Services through HHS issued many 1135 waivers, which eliminated the 3-day qualifying stay, which made a Medicare transition readily available for someone who was at a SNF level of care. So to your point that, and again, Larry may want to comment on this as well, when we did have the COVID recovery facilities, independent and dedicated units, I think there was an overwhelming Medicare eligibility reimbursement for those individuals. So that could still happen if they meet the criteria. And again, that is established through the minimum data set assessment that each nursing home has to do for each individual they admit. So I will stop there and perhaps give Larry or Matt and Mag an opportunity to comment on what you see your members doing. But again, I just want to reinforce that daily conversations, and we are providing technical assistance and support to any nursing home that reaches out to us. Larry, I'll stop
So
there.
wait,
Sure.
So before
Okay,
Larry,
yeah.
Larry, before you
Yes.
go, just let me finish my my thought pattern here. So Barbara, just real quick, since we are still in a public health emergency, and my understanding is that the feds are going to come out this week or next week and extend that, right? And my understanding is that perhaps it's going to be for the whole 2022 year. In that enhanced match, are any of those dollars, number one, dictated towards nursing homes? And then number two, under the enhanced match, does the Medicare reimbursement for the nursing homes still waive the 3 days? So that if they do open the COVID units, there's still an influx of Medicare dollars, which I thought covered the $600 day fee.
So I am not the expert on that, Representative Abercrombie. I can reach out to our regional office. We are meeting with them tomorrow. So I am happy to get more information on that. I would need to check the 1135 waivers as well. Those are continuously being updated, renewed. So I don't have the most current information on that. I don't know, Nicole, if you have other information. I know that's Medicare versus Medicaid, but I can certainly find out and do some follow-up on that.
And we can also reach out to Judy Stein. We are actually, just so people know, we're actually doing an informational forum with Judy Stein from Medicare Advocacy on February 1st, because there's some huge changes coming to Medicare around home care. And even though it's not our lane, we're Medicaid, we thought that it would be very helpful for our colleagues to understand a little bit about Medicare. But I think this might be an opportunity to save some state dollars through the Medicaid system if there is the opportunity for Medicare to pick that up. Larry, I understand the short staff. I understand, and I'm going to call it what it is, the price gouging that's going on from some of these private facilities that are bringing in workers and how much they're charging. So I totally get that. I don't think, I'm not judging anybody on the lack of workers. I think it's a crisis across all of the human services, not just the nursing homes. And I can tell you that we as a legislature are really trying to figure out how we can address that. I don't think that there's a magic bullet at this point that's going to do that. I think this has to be a long-term strategy. So let me just say that. Thank you.
Okay, I don't know, Matt, if you want to talk at all, but I could briefly talk about the all-COVID facilities. So we had the 4, all-COVID facilities, and probably, Nicole, what 80% of those individuals are probably covered by Medicare or managed care, thereabouts. So that, and that would apply to anybody that had a COVID case, right? So if they had it in the nursing home, 80% of that population probably was covered by Medicare. You didn't have to have an all-COVID facility for that to happen, or a COVID unit. But the reality is that, so Medicare does cover a good portion of that. And we also have COVID units. I've got probably 15 or 16 out of the 22 homes. But to varying degrees, as much as I could staff them, I may have a 5-bed unit, I might have an 8-bed unit. I would rather have a 30-bed because the need is substantial with the hospitals. And talking about staffing just briefly, Hartford Hospital, I think they have 400 or 500 employees out, and that's what I read anyway. So we're doing the same, so not just staffing shortage, it's people out with COVID, employees that have it. And so it's compounding the problem, but we're doing the best we can. Again, I had said before, we had 300 or 400 cases. Right now, we have about 310 cases in our homes that are all coming from the hospitals. But that's not enough because they still have almost 2,000 in the hospital. So, and we are where we're at right now. The only solution going forward is to cap the pools so this never happens again. To also find ways to get people back into our industry that they've had it. They're burnt out. It's been 2 years, and with minimal relief from wages for them, so they're looking elsewhere. But we can get it done. We just need. I need to show Nicole what we're actually spending, so we can figure out a plan to get those rates up and get people back in.
Thank you, Larry.
And again, yeah,
Appreciate
so that's it. Okay.
Thanks, Larry. Commissioner Gittani has to break away at 10:30, but if I could call on Commissioner Gittani very quickly, and please pardon my interruption.
Yeah, sorry. I just wanted to make a couple of comments, and I will try to come back on after the quick call that I have to take. First, Larry, I just want to highlight that after your conversation with the governor and Commissioner Gifford, I had spoken with all of them and investigated a number of the questions that you've raised regarding nursing pools. And for our legislators on the call, my understanding, and some of you may have more depth of understanding on this than me, is that there were nursing pool caps in the state of Connecticut. But that in the early 2000s, I was told somewhere around 2006 or something like that, that was repealed by the legislature. So, I think this is something that we had. It was reversed. I don't know the background or reasoning why, but that is my understanding, assuming that that was correct from some of the legal minds in our state government that shared that with me and have that institutional knowledge. And so the other thing I just wanted to comment on regarding sort of care of COVID patients, I think what we find is that, this is, as Representative Abercrombie mentioned, we're going to have times that it goes up and down, and this is going to happen probably forever going forward, just like we see with flu every year. And we're going to have to be prepared to be able to deal with that. One of the great things that's happened over the last couple of years is that nursing homes have learned how to do infection control practices and have been able to manage, we've had like 200 of 205 nursing homes in our state that have had COVID patients. And so I think that, creating dedicated wards within homes when you have so many patients makes a lot of sense to make it easier for the staff with the PPE and all of that is involved. But I do think we've come a long way, and I commend the nursing home industry for being able to manage when they do have outbreaks that occur within a home. So I think it's sort of this flexibility and agility with being able to ramp up how you care for these patients and maybe dedicate more of them to a certain wing in a home versus them, being within a home and finding ways to care for them within a home when they're already there. If they don't need to go to the hospital, it's not a question of accepting them from the hospital. So I just wanted to raise that point. And I will have to log off unless there's any quick questions for my comments, and then I'll come back on.
Thank you, Commissioner. So Larry, I wasn't sure if you had finished your thoughts, but I do know that Commissioner Jatani did want to make some comments. So please, again, pardon me for the interruption.
I'm all set, Barbara. Thanks. If there's any questions, I'll answer, but I'm all set. Thank you so much.
Representative Walker, good morning. How are you?
Good morning and Happy New Year to everybody. I apologize for not saying that because I haven't seen a lot of people that are on this call. I just want to go back to what Representative Abercrombie was talking about with Sue from OPM. The $10 million that we had put in ARPA is now being held for, and I didn't quite understand what the money is being held up for. If I could just get a little clarification on that, I would appreciate that.
Hey there. So the meeting, the funding was intended to, it was a small amount to assist with the issued versus calculated rates, as you know. But we are proposing to instead roll out a much broader plan to address over fiscal years 23, 24, and 5 to do a more full rebasing, which we felt would help position the homes better by addressing it in full. So that was the proposal. I know that Claudio there's been discussions with Claudio. I think, we should certainly have an offline discussion about moving forward. But that was the reason we didn't, is because we decided to make the commitment to go forward with the full rebasing and to get that budgeted.
I look forward to the conversation because it was in the budget and it was voted upon, as Representative Abercrombie said, and signed by the governor. And we've had numerous different other entities or items that we had there that we had the idea of using in other purposes. And OPM said that because it was in statute, that could not be corrected. So I look forward to having, I think we should have that as soon as possible. And I would hope that you could set that meeting up as soon as possible, because that was something that we had committed to the nursing industry in the first place. So thank you very much. Thank you, ma'am. Thank you for letting me have that question. Thank you.
Thank you, Representative Walker. Mag, good morning.
Good morning. I just wanted to briefly just support everything that Matt and Larry had said. From our sector, from our memberships, we're experiencing the same thing. And, we're experiencing the workforce shortage, as we said, in general. We need to retain, we need to bring people back, but we also need to attract people to aging services and provide training opportunities that are convenient to them. And I think we've learned that lesson with the online sort of temporary temporary CNA course, which brought in a lot of people who may not have ever had the opportunity to take a CNA course. So I just wanted to reiterate that, because right now we're having like a immediate severe staffing crisis. And I think, the Omicron variant is spreading through staff because of the high community spread. Even vaccinated and booster staff are testing positive. They may not be getting that ill, but they can't come to work. And so, we're experiencing this immediate crisis that's really causing an issue with admitting patients from the hospital. And it also is a space issue. When you admit someone who has COVID, if you don't have any other COVID patients, or if you admit someone who needs to be quarantined, you need to have extra space. You might have that extra space because you can't fill, because of census, you can't fill, you're not filling a wing, but you can't just put someone in a room without the staff to treat them. So we're working the best we can. We have members who have looked into setting up units, working to partner with other people, and staffing has been, right now they're just trying to work through that staffing to be able to get the staff to be able to staff those units. So, and I appreciate the commissioner's comments about our workforce and the fact that they have been able to develop this great expertise in infection prevention and control. And we are, almost every nursing home has COVID in the building, and just because of the community prevalence, and they are doing an excellent job in containing it and treating their residents who have it. So I just wanted to comment on that. I also just to follow up on something that Matt had said about, where we were when we set up these statutory, the statutory timeline for when we were all to sort of evaluate where we are with census. And to evaluate where we are with the acuity rates. The way that DSS has rolled out these rates, it gives everyone a terrific opportunity to evaluate how they're going to do in the next 3 years with the new acuity system. We truly appreciate the true rebasing that was done within that system. But we put a deadline of March 31st for everybody to do sort of a sector-wide, let's all take a picture of where we are and where we want to go. That we may want to take a look, this committee, or we may want to look with DSS at that date, because we didn't expect this current variant. We didn't expect the Delta variant, as Matt was saying, and so a lot of what's holding us back is staffing and the demands out there, but we just can't take these patients. So we just may have to take a look at that and see if maybe a later date would give us a better picture so that we can plan a little bit better. We really like the idea that we're all going to take a landscape view of the nursing home sector to say, okay, where is the demand? How many beds do we have? Where are they sitting? And what are people's plans with the new system? But maybe March 31st is going to be too soon. I don't know. I can't say that right now, but it may be too soon for us to get really an accurate picture based on the pandemic. So I just wanted to make those couple of comments. Thank you.
Thank you, Mag. Senator Austin, good morning.
Good morning, Barbara. How are you?
I'm good, thank you. Happy New Year to you.
Same to you. Although I've decided not to even proclaim holidays anymore because we haven't really had one in 3 years. So I'm giving up on proclaiming, not on anything else, but giving up on proclaiming them. I have a couple of different questions, and I don't know who it would go to. Relative to the budget, I agree that the $10 million needs to be better explained to the legislature. It needs to be better explained to the legislature before we get back into session so that we can make sure that we're understanding what the administration is attempting to do. And I don't really need to get an answer on that now. I'm assuming we're all going to have a meeting on that. Relative to the staffing shortages broadly across job classifications, do you know, and I would think that this might be for Mag and Matt, has the Workforce Strategy Board talked to either of you or to the nursing home industry on their needs? They have $70 million, of which they're utilizing $62 million on training. And if we can broadly start training people at, in mass, that seems to me that would be a good thing for us to do. And I would remind everybody that Representative Walker put in the budget the last, not this last budget, because we had a different plan, or I think we might have put it in this budget too, $500,000 a year over the last 3 or 4 years to encourage training on CNAs and other entry-level people into the nursing home or healthcare industry. So has anybody contacted you relative to that, using those dollars for entry-level positions in the nursing homes? Mag or Matt?
First of all, I think what you've expressed, if it's a suggestion or something that you believe needs to happen, I guess I would say I 100% agree with you, and I think it will happen. And it has to be an essential part of the longer range strategy to build those connections. I know that they have looked at the sector's healthcare needs, not just nursing homes, but hospitals and across the system in the past. And I think we suggested in a presentation that we made to the healthcare cabinet, and it was a joint presentation from MAG and I, the hospitals and home care as well, that those bridges to the workforce and investment strategies generally in Connecticut needed to elevate, or our suggestion was should elevate the healthcare component of that. And we're fully expecting that to happen, but I'm not able to say that we've had a recent reach out on that. Mag, do you have anything on that?
Yeah, I mean, it's been very regional, the approach, I believe. I have a few members who worked with them on some projects. We have had touched base with some of their members through an initiative that Matt and I are working at with the Connecticut League of Nursing to try to develop some work in the post-acute care setting, developing the nursing personnel, but not from a general system overwide. And I think that's, I think we need more of a sector-wide approach and they seem to be they have done very regional work. And I'm not criticizing, I'm just my observation.
I'm not criticizing either. I'm trying to get data, that's all. Then my other question is concerning the salaries of nursing staff and the nursing pools. It's really not about the nursing pools. What is a wage? Do you have wages that are acceptable to the industry for the job classifications that we're talking about? CNAs, maintenance, RNs. Is there an idea on what that should be? Because I've been reading articles relative to people that are being brought in with on visa programs to help out with staffing shortages. I think it was Montana was one of the latest articles that came out. So is there a standard wage that you're looking at paying these job classifications, physical therapists, et cetera, et cetera?
I'll ask Larry to add to that, but and we do understand that just the sort of laws of supply and demand do increase these costs, and there is something reasonable from the pool agencies. I believe Larry has suggested to the administration that CNA should be capped at $35, LPN incrementally higher, and RN at the highest amount. Maybe up, and I asked Larry to correct me on that. It might be 35, somewhere in the range of 50, and maybe up to 75 for RN. Of course, these are significantly higher than that is the standard wages being paid either by way of collective bargaining agreement or generally in the industry. I think clearly we're moving, just as an example, we're moving in very close to $20 an hour for the CNA position, and so I hope that's responsive to your question. But that's kind of the ballpark on the capping. We do see the continued wage pressure, or we see that there's going to be continued wage pressure even at the $20 an hour. And I do see a future where I think the system is just going to have to be responsive to increased wages for these essential workers. And that's something we'll have to continue to talk with you about, with over 70% of the nursing home population being Medicaid. Then obviously there's a very sensitive dial between paying those increased wages and Medicaid expenditures. But I believe those investments are really, really smart. Invest in this workforce, and that's part of the overall strategy on top of some of the things Mag had mentioned previously.
Mag?
Are you referring specifically to the pools or to our general staffing?
No, the pools are in reference to my opinion is the pools are in reference to the fact that you don't have anybody to put in those positions. But what is the standard wage for someone that's working regularly in a nursing home environment? What do you think is, because we raised, go ahead.
No, I was gonna say, you can't share wage information with each other as members, they can't share.
Right.
But what we do every year is we gather that information blindly and provide a salary survey for our members so they can see what the competitive, what the rates are. We recently just did an update because everyone is increasing rapidly their wages to attract people. So I think people are paying what the market whatever the market is requiring to bring people in, both in the dietary, housekeeping, engineering, as well as direct care CNAs, LPNs, infection preventionists, all of the different social workers. So we do have sort of a standard of what people are currently paying based on a salary survey.
Well, thank you both for that, because the reason why I'm asking that is because it's going to impact the budget, right? It is going to be an impact on the budget because you're going to expect, and I believe should, receive compensation relative to the largest piece of any nursing home budget, which is personnel. And so I just think we have to pay attention to what that is going to be. And I, having been part of the budget for a little bit now, paid attention to when we went up to $15 an hour, shortly thereafter to $20 an hour in bargaining with the groups that represent generally the lowest paid people in your environment. And I just think that this is something that we should be able to project. I don't need to know what nurse A is making, but I certainly need to know what nurses in general are making that are going to be that nursing homes are expected to get repayment on. So I just that is something that I think we really have to pay close attention to, and whether it's through this group as the finances, I do think that that we should have a 5-year projection on what this is going to be. And I think this group is a perfect group to do that 5-year projection so that we have an idea of what the out-year costs are going to be in the oversight of the budget. And so and I just sort of wanted to know that when I read the article from Montana, it said that they were paying up to $200 an hour for some flying in some nursing staff. And we're going to have to grapple with this because it's not going to go away. And I also don't think that, I'm hoping that, God willing, I get found wrong. But I think we have to figure out how to live with whatever variant is going to be here. I think that after this variant, there'll be another variant. And after that variant, there's going to be another variant until we figure it out. And while not exactly the same, we did use Uncas on the Thames at one point, many years ago, decades ago, to help out with this kind of situation where people with tuberculosis were housed because it took them so long to recuperate. We don't know what's going to happen. And while we're telling the nursing homes that we expect them to take COVID patients, should we ever get a variant that is going to be much more difficult or have long-ranging consequences, which has happened, we're going to have to figure this out. And this is something that I think we should also have a real discussion on relative to what we're expecting and trying to figure out what that long-term plan is going to be. And it should be, again, this kind of group, because it's a financial cost and essentially think it's fine if we want to tell nursing homes that they should take people in, but you can read the backlash on that in many newspapers, in particular in the comment section, if you're of the mindset to ever read the comment section. I would caution you because sometimes it can be, you know, they can be a little bit rough sometimes. So just saying. But those are two things that I think that we need to sort of start preparing for, is what we're going to do should COVID come up with another variant. I mean, I'd be very happy to be proven wrong and that COVID goes away completely. I just don't happen to think that that's true, but I'm not a doctor. So, all right. Thank you.
I think I can help just on that. We're going to be doing that study, which is going to show our average payroll costs now compared to pre-pandemic. I did do that study for the state of Massachusetts, and we had an average hourly rate, for example, for nurses' aides of $23 an hour that went up to $35 an hour. And the reason that went up so significantly was because of the bonuses you have to pay, one, to work on a unit that has COVID, two, to work 3 to 11 or 11 to 7. So these are pickup shift bonuses that average around $300, which is $30-something an hour, right, for the 8 hours. So that significantly built up that average rate. So if we do it for Connecticut, which we're going to be doing, we can actually tell exactly what we're spending now and what the average hourly rate should be for the industry. I still believe the base rate has to be somewhere around $23, $25 an hour at this point to bring nurses' aides back in. But we'll have all the facts. So I'd rather wait for all the facts to come out in the next week or so, and then we could, distribute them to the committee and see what we think.
Thank you.
Thank you all for those comments. And Senator Austin, I just would like to just piggyback on the staffing and the workforce, the work that's being done at the state level regarding addressing workforce issues. And I know the commissioner's offices at both DSS and DPH have been reaching out to the governor's office and the group that is working on that. We have also publicized and expanded our temporary nurse aid workforce as well. And we have extended that or access to the temporary nurse aid to the hospital community as well, who, as we've noted on this call, are experiencing workforce issues as well. So while that's one small piece, I do think that temporary nurse aid role is and has been helpful, and it does at the local level provide the nursing home the opportunity to certify that person. So work continues on that area in trying to build a nurse aid workforce. So I don't see any other comments, any other hands. Again, we appreciate all the work that's being done across the sector. We are grateful for the heavy lift that nursing homes are doing right now to care for our, in my mind, our most vulnerable population. So we are grateful for that work. Nicole, I will pass over to you for any final comments.
No, thank you, Barbara. No final comments. Just to reiterate our promise to be able to give the committee, so through Melissa, we'll send follow-up to the questions that we were asked, in particular around the CRF audit recoupment amounts and Representative Walker's question around the total amount for the 4.5% wage increase. So through Melissa, we'll send that information so everyone on the committee can see that. If there's any after this follow-up questions, you know, feel free to reach out, and we were happy to get additional information out to everyone in the meeting. So thank you.
Thank you, Nicole. Melissa, any closing comments?
No, we're all set, Barbara.
Thank you all very much. Stay well.